Good morning, colleagues. Bear with me 1 minute, please. All right, Dr. Bolivar, Dr. Kuretski, are we ready to go? Yeah, wonderful.
We're ready.
All right, great. Okay, so good morning, everyone. Welcome on behalf of the Pan American Health Organization to this session today, Optimizing Health Across the Lifespan in People with HIV. Our presenters today are Doctors Hector Bolivar and Jenn Kuretski. Welcome. It is my pleasure to facilitate this really important session on health across the lifespan for people living with HIV in the Caribbean. Colleagues, as you know, over the past 4 decades, the HIV response in our region has undergone a remarkable transformation. What was once really considered a life-limiting condition is now for many a manageable chronic disease, allowing people with HIV to survive, thrive, and contribute meaningfully to their families, communities, and societies. As people with HIV are living longer, healthier lives, our response also must have to evolve. Today, we're challenged to think beyond viral suppression and consider the changing health, social, and psychological needs of individuals across every stage of life. Hence, our discussion and this session this morning. I encourage you all to use this session as a really good opportunity to reflect on and share practical experiences and innovations that will help ensure that every person living with HIV can achieve not only a longer life, but a healthier, more meaningful, and more dignified one. To get us started at this time, I will launch a short poll. Give me 1 second to do this, but I encourage you to go ahead and respond to the poll. Okay, the poll should be up on your screen. Dr. Bolivar, can you confirm that the poll is up on the screen?
Yes, we see.
Okay, great. And so while colleagues, you're responding to the poll, I will continue. Just a very kind reminder on housekeeping. Your mics are muted. I encourage you to type any questions that you may have using the Q&A feature, and we'll take them at the end of the presentation during the Q&A segment after the presentations. At that time, you could also raise your hand and we'll allow you to unmute and make your intervention. Please, there's no need to take any photos of the slide. I will email them to you in the upcoming days. We have, as you continue to respond to the poll, we have Dr. Hector Bolivar who will present. This will be followed by a case study from Dr. Jenn Kuretski. And just to give you a little bit on our presenters, Dr. Hector Bolivar graduated with his medical degree from the University of Quindío School of Medicine, Colombia in 1989 and continued his medical journey with internal medicine residency, internship and residency at Albert Einstein School of Medicine in New York, fellowship in infectious disease at the University of Texas Health Science Center, and as a fellow clinical immunology and HIV at the University of Miami affiliated hospitals. Dr. Bolivar has also postgraduate experience at the Division of Human Genetics, National University of Columbia School of Medicine, and at the City Hospital, Edinburgh, Scotland, UK. Dr. Bolivar has worked extensively with HIV patients and is currently the Chief Scientific Officer and Principal Investigator, Atlantic Clinical Research Institute, and the Chief Scientific Officer at Midway Specialty Care Incorporated in Florida. And to present our case is Dr. Jenn Kuretski, who graduated in 2008 from the University of Florida College of Nursing with a Bachelor's of Science in Nursing. from the University of Miami School of Nursing and Health Studies with a of Science in Nursing, specialization in family nursing. And in 2011, from the University of Miami School of Nursing and Health Sciences with her Doctor of Nursing practice. She has received many, many accolades during this time, including being on the President's Honor Roll at the University of Florida and on the Dean's List on multiple occasions. Dr. Kuretski is the Director of Research and Education at the Atlantic Research Institute and Director of Research and Education, West Palm Beach Clinic, Midway Specialty Care Center, and she's also their nurse practitioner. I can see that our participants are still responding to the poll. So I can ask you, Dr. Bolivar and Dr. Kuretski, to get your presentation up, but we can allow maybe a minute or two more for our participants to continue responding to the poll. Is that okay?
Sounds great.
Yeah. All right. Let me see where we are with the poll. We can give a few more minutes. I see that we have a little less than half of our participants who have responded. So colleagues, please go ahead, give it your best shot. So again, Dr. Bolivar will present, and then we'll have the case from Dr. Kuretski, after which we will open up for discussion for your question and answers, for you to share any of related cases that you may have in your own practice, whether it's an experience or whether you would want to ask a question on a particular case that you're managing or would have managed. So please, as the presentation is progressing, go ahead and type your questions or your comments. I think you could use the reaction feature on your webinar panel or on your Zoom platform to be able to react to our presenters, maybe a particular message that you like. You can give the thumbs up, you can give an applause. Let this be as interactive as possible, and we'll open up during the question and answer segment. Dr. Bolivar, could we give maybe one more minute and then I hand it over to you?
Sounds good.
Thank you, Dr. Jenn.
I turned our video off just for simplicity, so that way this takes up the least amount of space.
Okay, I will go ahead and end the poll for now, and I'll hand it over to you, Dr. Bolivar.
Thank you, Dr. Singh. Thank you for the invitation. We will start with the introduction and some disclosures, passing to Jenn, and then I will present my part.
Awesome. Yes, thank you, and welcome everybody to Optimizing Health Across the Lifespan in People with HIV. These are some of our objectives that we're going to cover today. So first, we're going to start with a brief overview of the biological mechanisms of why people with HIV experience faster aging. Then we're going to transition to a more clinical conversation associated with comorbidities and management of those comorbidities in our patient population. We'll discuss some evidence-based strategies to optimize long-term care in the populations in which we serve, with a focus on the integration of a multidisciplinary team. And then as Dr. Singh shared, we will have a case to share. Here are a few disclosures for us on this screen.
Thank you, Jen. So one of the things that we have nowadays with HIV, when patients are in treatment, is that definitely they are living longer. HIV transformed from a deadly disease to a chronic condition. But one question is not only for HIV patients, but for non-HIV patients, what is aging? There is discussions how to define aging, and the first thing that we have to differentiate is there is something called biological aging, that is the progressive time-related decline of cellular and tissue function. And there is the more traditional definition of aging, that is the chronological aging, that is the exact age in years, measuring the number of years someone has been alive. This is what we account when we celebrate birthdays or anniversaries. However, there is a discrepancy between somebody with 80 years old chronologically, what does it represent biologically? And this is the major issues in science and how to define and how to account for biological aging. There is a very high interest in terms of the consequences of an aging planet. The humankind is living longer. If we take the whole planet as a one single country, definitely if we account for the life expectancy, people is living longer. Obviously, there are regions where there are wars or sociological constraints to have a lifespan that's similar to in other countries. There is a lot of discrepancies in the life expectancy, but if we take overall the whole country, definitely the humankind, this is the era in history that we are living the longest. It's calculated by the WHO that by 2050, around 426 million will be over 80 years old. Already, the most recent data from 2019, around 143 million people were over 80 years old. If we think how this is going to impact, that is impacting the health care and many other aspects in our daily life, this is important to take in account. Nowadays, the median age by regions, there are countries that are continents that are aging faster or no, aging faster. Actually, the proportion of people over 80 is higher compared with other continents. We see here, for example, in the United States or North America, the average age is 38.9. In South America, 32.1. The problem is we move to countries in Europe where the aging population is growing faster and there is not enough people to live, to born, and the demographic impact of a huge proportion of people over 80s or elderly people with a minor proportion of people 20 in the reproductive age is already impacting. There are countries like Russia, for example, that even before the war now, the demographic natality, the demographic rate is lower. People, places like Italy and Spain, they are having issues with how they are going to have enough young people in the future to go for the development of the country. So this is very important. Even in Africa, with all the problems in many countries for development in health and education and cultural development, still there are overall, taking into account the whole continent, the life expectancy is improving. So why do we age? Another question that is fascinating scientists working on this topic. This is a molecular, actually it's a solar clock. This is how in the old times people used to measure for the pass of time. But why does it mean in a cellular level aging, biological aging? There are many explanations. No, every explanation account for all the different conditions. The earliest theories is that there is this genomic instability, meaning that every time that the cells divided accumulate mutations and changes, and there is this predisposition, genetically predispositions that some people may age faster than others. Every single of these theories, actually hypotheses, is enough for 1 hour lecture or more. So yes, I'm going to mention the title and a little bit of everything. There is another observation, the telomere attrition, that is this part of the chromosomes in the cap of the chromosome, that every time there is a cellular division is shortening, and this has been associated with also lifespan. This is all observational, don't necessarily having longer telomeres, meaning that we're going to be longer, but the commercial companies that are trying to sell medications or supplements to alter these telomeres or one of these processes is not based in real science, so just a comment apart. The epigenetic alteration is like how the environment, even if we're born with some genes predisposed to certain time of life, certain span of life, how the epigenomic phenomena are doing alterations and in our cellular and tissue level. Things like smoking or alcohol or an unhealthy life may cause alteration in our genomic backgrounds. The cellular senescence, a very popular theory that happens back in the 80s, but now is not probably very favorite, also meaning that the cells are aging every time that are dividing, and there is a limit of divisions in our cells development. And the one that is taking probably more importance over the last year is the mitochondrial dysfunction. We have these structures in our cells called mitochondria that produce energy by ATP. However, as we age, the quality of energy production by the mitochondria is less and less, and that's the less energy that we have and we accumulate over the year that are contributing and probably the background of aging. At the end, none of these explain 100%, but there are different lines of investigations trying to find out why we have this biological aging. In HIV, as Dr. Shin mentioned in the introduction, we have moved from the early 80s when the virus was initially discovered and the AIDS epidemic started. And before the introduction of medication, the lifespan of somebody diagnosed with HIV was about 10 years. Almost 100% of the people diagnosed with HIV on those years were dead by 10 years. Because the immune system decreased and there was a lot of opportunistic infections that finally caused the death of the individual with HIV. However, back in the 90s, 96 actually, the introduction of medications, the very effective antiretroviral therapies, combination, different cocktails, changed the history of HIV, and is this one of the most remarkable achievements of the history of science and history of medicine. How we transform in a relatively short period something that was deadly, a death sentence, to something like today, a disease that is a chronic condition. So somebody today starting therapy early when the immune system is still not very effective can expect to have a relatively normal life or normal expectancy compared with people without HIV. It has been calculated over the last years that nowadays, year after year, with better medications, with early diagnosis and the introduction of therapies very early, that the lifespan for somebody living with HIV, for a person living with HIV, is about 77 years. And in people without HIV is about 80 years. There are 3 to 5 years probably difference. Obviously, this happens in countries with resources, in places where we have the luxury to use state-of-the-art treatments, that we have the capacity to do diagnosis, that we have the infrastructure to do follow up with the patients and follow the patients closely. Unfortunately, this is not what it happens everywhere, and there are still places where people is like 25, 30 years ago or more in the early days of HIV and the AIDS epidemic. But there are improvements, and we are moving to this, and I hope that in the next 15 to 20 years, most of the people with HIV will have a life expectancy like we are showing here in the presentation. So there is definitely the biological aging in HIV patients is accelerated, even in the best case scenario. Jen is going to discuss more in details what is behind that, what this is the reason for this biological accelerated aging in HIV. And one of the translations from basic science to the real life is in this figure that I have the quotation there in the American College of Cardiology. The solid line in the middle is normal aging individuals in countries like Japan is 87 years old. This is probably the country with the longest life expectancy, also Scandinavian countries. And in the United States has decreased about 3 years over the last 10 years. And another impact was COVID. But let's assume that the normal span is 80 years old. Definitely having delayed vascular aging improve the quality of life and increase the life expectancy. But if we go below if we look into below the solid line, if unhealthy lifestyle like smoking, or there is a background of family history with cardiovascular disease, so the life expectancy start decreasing more and more. Diseases like diabetes decrease the life expectancy, chronic diseases, chronic kidney diseases, autoimmune diseases, and HIV virus is right there in the red color. There are also genetic conditions that cause premature vascular aging and accelerated aging. So what happened today is that even though patients with HIV live longer, we are observing that they are more prone to have these conditions that are below the solid line, like diabetes, metabolic syndromes, and many cardiovascular conditions that shorten the life expectancy. And it happens because the virus is integrated into the chromosomes, is latent there, it's not replicating, but it still is causing signaling to the different tissues and different cells. This is translated into accumulation of damages in the different organs, the brain, the liver, the gastrointestinal system, the neurological system, and accumulation of fat in the form of adipocytes. And at the end of the game, this is impacting the quality of life and life expectancy. And I pass now to Jenn, that we will go in details of some of these aspects. Thank you.
So now, building upon what Dr. Bolivar had shared, now we're going to transition to what that looks like clinically for a lot of us as we're providing care for people with HIV across the world. I think this picture is a beautiful representation of where we're currently at in managing HIV. So before, our aim was saving lives, viral suppression, avoiding opportunistic infections, treating opportunistic infections. And now viral suppression is the entry point to HIV management, and we're building upon that. And this picture demonstrates that. This is a gentleman who's running or perhaps walking maybe very quickly, and looks to be in a relatively healthy state. His weight is good, his color is good, and he overall looks like he's feeling well. And so this is a great demonstration of where we're at with helping people with HIV age, not just aging, but also aging well or better than perhaps we had in the past. Dr. Bolivar had touched on this. We know that we've come a really long way over time, and now we're transitioning to that right rectangle on this side with healthy aging, where before we had mentioned that the goal was survival, the goal was viral suppression. Well, we're building upon all of that. All of that had to happen first for us to be at a place where we have healthy aging, where now we can focus on chronic disease management, preventative care, healthy longevity, and improving quality of life in those in which we serve. And so now I found this quote: "The greatest success in modern HIV care is no longer measured by viral suppression alone. It's measured by helping our patients live longer, healthier, and more independent lives. And so again, none of this would have been possible without the years of work of scientists, providers, everybody working together to be able to make HIV viral suppression a reality for most. And now we're building upon that. This little flow chart here is just a brief review of what we had shared before, where even with viral suppression, some people we know still have persistent inflammation. They still have that ongoing low-grade inflammation. We know that there is some underlying immune activation. There's a lot of research in this area trying to understand what does this mean, and are there differences in antiretroviral therapies and their ability to help with this level of inflammation. And what does that mean clinically for us? It's in the orange and the red boxes that we see there. Is it a role, or is there a role in frailty and the development of chronic diseases? We're seeing that. And so although viral suppression is important, it's the entry point to any of this. Now our focus transitions to frailty and management of those chronic diseases. And just as a kind reminder to ourselves, we all know this, but viral suppression is essential. We can't have any other conversations until we get there, but it doesn't always mean immune normalization. And so that brings us to our first clinical topic of the day, which is frailty. And frailty, as you've seen in the research literature, has become much more of a common topic. There are many tools to assess frailty. To kind of set a foundation for the next few slides, our definition of frailty in which we're using is a biologic syndrome characterized by a decrease in physiologic reserve and an increased vulnerability to stressors, which may pose a higher risk for adverse health outcomes. And so ways at which we can look that from a physiologic system perspective is a decrease in strength, endurance, mobility, physiologic reserve, and then ultimately, the concern would be vulnerability to illness and hospitalization. And so clinically, what do we see when we're talking about frailty? Perhaps increase in falls. We know that sarcopenia, the loss of muscle mass, can contribute to weight loss. Slowing of gait speed, which is why gait speed is a part of many frailty assessments, as well as decreased grip strength, self-reported fatigue, and then reduced physical activity. And this matters because we know that people with HIV may experience frailty at younger ages due to that chronic low-lying inflammation we spoke about, the presence of multiple comorbidities, perhaps polypharmacy, and then acknowledging that social determinants of health, access to food, water, stable housing, things like that also definitely play a role in overall wellness in the people in which we serve. And so just a reminder that frailty is more than the chronologic age, right? Sometimes we feel older than maybe what our age is, or maybe when we're actually implementing the things on the screen, good physical activity with strength building exercise, getting great sleep, working on our mental health, improving our nutrition, we perhaps feel a little bit younger. And those are the things that we want to encourage people to participate in and engage in as we all are aging. So that's just a baseline of what frailty is. And now we're going to talk about how do we measure that. So there's many different ways in which this can be done. There are many, many tools available to assess frailty, some longer than others. But they all more or less incorporate the four components you see on the screen: physical performance, nutrition, functional assessments, and social health. We talked a little bit about, grip strength and gait speed. That is something that's important. Nutrition, we talked about sarcopenia. We know that protein intake becomes very important, especially as we age and we're losing muscle mass. So protein intake combined with weight-bearing exercise or weight exercises is very important. Assessing for the ability to complete activities of daily living, assessing for the presence of falls, perhaps completing home visits to understand exactly what the home looks like to see if there are potential areas where falls could be a risk. And then social health. And this is probably arguably one of the most important and something that we have to consider as we all age. Screening for depression, we can do that very well, but also assessing for social isolation. Do they have support system? Do they have a caregiver who's able to be there with them? That plays a really big role in not just the physical, but the mental health component too. Very simply, we included just a couple of the quick reference, the very quick tools that can be used to assess frailty. We do acknowledge that there are many, many other ones out there, but these were the ones that were most simple to use. The clinical frailty scale, this is simply something done based upon what we see and learn during a routine visit. It takes less than a minute to complete it, whereas the other two do require some questions and prompting from the patients. And then again, of course, there's ones that are much longer, but for purposes of today, we were including the short ones that could very easily be implemented into a routine visit as they take no more than a minute to 2 minutes of our time. So now we've talked about frailty, we've talked about assessing frailty in a standardized way with validated tools. Now we're going to transition our focus to preventing and reversing frailty and talking about it from a multidisciplinary approach. So overall, the goal is to have improved function, right? Improved quality of life. Well, what does that look like? Encouraging patients to exercise, encouraging a nutrition or a diet that helps to meet all of the needs of aging with a focus again on making sure we're consuming enough protein. Optimizing medical care, I think that's the easiest one for healthcare providers because that's the one that we have the most control of. But encouraging people to continue to adapt their lifestyle to aging through exercise, nutrition, and then also psychosocial health can be more challenging. But whether some people may or may not have access to talking to somebody about nutrition, do they live in a place where it's safe enough for them to be able to go outside and exercise? Is the weather, acceptable enough where they can do that? Those are things we have to think about. And then last but certainly not least is addressing psychosocial health. So supporting mental well-being. And we're going to talk about this in a little bit more detail in a few slides. Thinking about mental health, not just as an assessment of depression and anxiety, but also looking for signs of isolation and fulfillment in life. Next is the concept of polypharmacy. And polypharmacy is something that unfortunately sometimes comes alongside the presence of multiple comorbidities. And so this is just a screen just of what the realities of sometimes life are. So we have patients coming in, they're at a minimum taking their antiretroviral therapy. And then now we know there may be comorbid cardiovascular conditions. Perhaps they also are battling diabetes. Perhaps they're taking a medication for their mental health support. And then there's, of course, all of the over-the-counter supplements that are available. And so being very mindful that every visit they come into us, we're completing that comprehensive medication review, looking for possible opportunities for de-escalation, if at all possible, and then monitoring for drug-drug interactions, as we know that as medications change, that's something that we always keep an eye on. So now we'll transition to the concept of some of the other major comorbidities. We already briefly discussed the concept of cardiovascular disease. And we know that chronic inflammation and immune activation are key drivers of atherosclerosis in our population. We know that early prevention is essential. And thankfully, in the last year, we had the giant REPRIEVE trial that did demonstrate that. Many of us know we had used statins for many years as prevention measures in people who had ASCVD risk above 10%. And so now we're thankful that our population, people with HIV, have also been considered for early prevention. And so the REPRIEVE clinical trials showed that, showed a significant reduction in cardiovascular outcomes such as MI, stroke, in our population, thus recommending that people be started on statins as a prevention, not necessarily waiting for hyperlipidemia. And so that was really great to see HIV acknowledged as a comorbidity for that, to be even considered in that study. And the multidisciplinary approach, just emphasizing that none of us can do this alone. If people have access to other means, like I said earlier, of a nutritionist or other professions that are able to help drive outcomes or improve outcomes in our population, that would be great, because everything that we do today can help us later on in life with aging. Next is metabolic health, and we purposefully had weight gain as the first circle here because weight gain sometimes, eventually, We see diabetes, obesity, fatty liver disease, and hyperlipidemia tag on after that. Of course, the other ones can happen on their own, but it usually starts with some degree of weight gain. So we know we see weight gain. There's been many studies over the years that have also questioned the role of antiretroviral therapy. Um, we used to celebrate weight gain, and we still do to a degree when we have someone who's treatment naive and they had lost some weight from the time they had acquired HIV to the time they start treatment. Then we would celebrate that weight gain as that return to normalization. But then there becomes the question as people are aging, how much weight gain is just too much weight gain? And then, of course, diabetes. So we're going to see, I think we're already seeing a lot of this. I'm sure many people here could share stories on that. Our case that we have today to share is a gentleman in which we provide care for who had an onset of diabetes after a diagnosis of HIV much later on. Obesity, of course, this is a problem that we're seeing. Likely a combination of factors leading to that, but something also under study. Fatty liver disease. Now that we know that there is a medication approved for it, in addition to consumption of like black coffee or the vegan or Mediterranean diet, which can also be helpful to help reduce fatty liver disease. We know that there's other things that can potentially be done. And so now being mindful that we're also considering the long-term effects of fatty liver disease in our population and putting that into the same bucket of metabolic health considerations, just like alongside diabetes, obesity, and then hyperlipidemia. Next is kidney disease. So thankfully, a part of the guidelines for many, many years have been monitoring for urine protein, have been monitoring for kidney function, estimated GFR over the years. Just as a reminder, that still is very pertinent as we age and as the patients that we provide care for age. Constantly reevaluating whether or not medication dosing needs to be changed. As people age, we may need to do that, or perhaps with the addition of a new medication dosing may need to be adjusted, or the medication itself due to drug-drug interactions. And then being mindful as people age that medications that are more likely to serve as nephrotoxins are avoided as much as possible to try to preserve as much of the kidney function as we can. Then we have bone health. So DEXAs are recommended in postmenopausal women and men over the age of 50 with HIV. So we know that we can get that completed if we have access to it. But even if we don't, recommending people to do things to help contribute to their bone health, whether that's consumption of vitamin D, exercise, falls, making sure that we're helping with fall management, teaching people how to fall gracefully as opposed to falling abruptly, which is easier said than done. My brother-in-law is a physical therapist, so he always tells us that to teach people to fall gracefully, and that will save a lot of injuries. And then, of course, fracture prevention as much as we can. And then mental health. So this is where we see depression, we see substance use, things that we typically think of for mental health. But also thinking about HIV-associated neurocognitive disorder. Although we're not seeing as high of rates of HIV-associated dementia, but are we starting to see some subtleties in maybe just some simple forgetfulness, a little bit of decreased ability for concentration in our population? So I think as we start to see more of our population aging, we'll start to see more routine assessments for hand to be performed, so we can really try to understand, is there anything else that we can do along the way to perhaps support them? A focus on sleep. I know this is the most common thing that I feel like is a complaint when people come into the clinic. They feel like they're not getting enough sleep, or they're not getting enough restful sleep. And so trying to work with people to improve sleep hygiene, which would overall help their overall well-being. We know sleep is very restorative and very good for the body. So helping people to be able to promote really great sleep habits. And then I want to mention loneliness too, because I think this is something that is really important. And I think we're seeing it a lot more. Many of us likely provide care for people who are long-term survivors. And so they were likely diagnosed in the early 90s, and they have survived to this day. And I found myself having many, many more conversations with people in the last year about the concept of loneliness. And it comes from multiple factors. As they're aging, they're in their late 70s, early 80s. They're also noticing that their friends are no longer necessarily here, and they're wondering how they made it, despite the fact that they lived through one of the roughest times in the HIV pandemic that had happened in the 90s. And there's also a little bit of the fact that they're also reflecting on where we're at, and they look back and wonder again how they lost all their friends over the years. So I find loneliness to be a very big conversation in, again, the older population in which we provide care for. And I don't get that information from the PHQ-9 for depression assessment or for a substance use history. It's getting to meet people where they're at and kind of what's going on in their life, who is their community, that I've been able to develop an understanding of what that concept of loneliness is for them and helping connect them to support services or support groups in the area. So that way they no longer feel alone or help to at least reduce some of that degree of loneliness. So those are some of our chronic comorbidities that we think about in the aging population. And I'm sure when we get this presentation in a year that it'll be very different. And we're all open to what that may look like. But now a transition and a focus to the prevention side. So how can we screen for cancers? And so this table just very simply puts together screenings for the various types of cancer and then what the recommendations are and are there any special HIV considerations? So for colon cancer screening, screenings in people with HIV are still the same, recommended ages 45 years and older, starting at 40 if needed based upon family history or other risk factors. Breast cancer screening is still recommended either every 1 to 2 years after the age of 40. That varies based upon the guideline, but HIV does not play a role in that. Cervical cancer screening. So cervical cancer screening is more frequent. So we do know that for persons ages 21 to 29, we recommend cytology screening. We do that once a year for 3 years. And if all cytologies are negative, we can go to every 3-year cervical cancer screening in the population 21 to 29. But then what's really interesting is the group 30 and above, we do co-testing. So it's recommended to do cytology with HPV testing. And that is recommended at a frequency of every 3 years if those tests are negative. Of course, if a cytology or HPV test comes back negative, that puts them down a different follow-up time interval. But we know that in the general population, that cervical cancer screening above 30 is every 5 years. So again, for HIV, every 3 years. So that is a little bit different. Lung cancer screening, same as the general population in terms of smoking prevalence. Anal cancer screening. So these guidelines had come out, and we anticipate these will change over the years as well. Being able to perform anal cancer screening and anal cancer screening follow-ups is highly dependent upon resources available in the area. You have to have somebody to be able to follow up on a positive cytology or a positive HPV screening for anal cancer. So that is something to acknowledge. And we know that our population, even through sexual orientation, how people have sex, and that also plays a role in the need for anal cancer screening. And then liver cancer screening, obviously in those who are also co-infected with either hepatitis B or hepatitis C, being mindful that we do screen for hepatocellular carcinoma too in our population. So in summary, we put together this slide just as like a checklist. So when Dr. Singh shares this with you, you can also use this as just a nice little checklist of all the things that we consider for people who are aging with HIV. We touched on each one of these during the last several slides. The only one I want to draw extra attention to is the bright green box in the bottom left corner on vaccinations, because we haven't yet talked about vaccinations, but vaccinations are a way in which we can help with prevention. And so we do have our vaccines, influenza, recommended annual influenza vaccinations, the COVID-19 vaccination, pneumococcal. There is a new pneumococcal conjugate, the PCV21 vaccine, which is recommended for people ages 50 years and older, or it can be given younger in people with immunocompromised conditions such as HIV. So that would be great to be able to offer that. The Shingrix, the RSV vaccine, and then of course hepatitis A and B. That's been a longstanding part of HIV care since the beginning. And so those are things to consider too, in addition to everything else that we had spoken about earlier. Now, what can we do to help people to optimize their long-term care? We had put together this little algorithm, again, just to serve as a helpful reminder of every time we're seeing patients, we're reviewing comorbidities, we're performing medication reviews, and I would bet all of us do this in our head without even thinking about it. We're assessing for what their most recent GFR was. Are they at risk for osteoporosis? Are they on a medication that could contribute to that? Are they taking other medications that could perhaps interact with our antiretrovirals? And then, of course, considering resistance history. And we simplify regimens whenever we can. Again, probably everybody, we all do this in our head without even thinking about it, but putting it on paper, that's what it actually looks like. And then we have a shared decision-making model with our patients to be able to decide what regimens or what regimen they would prefer to take. And then from a treatment perspective, in addition to antiretroviral therapy, there's a lot of literature out there now about the concept of lifestyle medicine and using our lifestyle as a form of medicine, not to replace medicine that's needed for treatment of chronic diseases, but to use it as a supplement. And whether that's exercising, it's recommended per lifestyle medicine to exercise at least 150 minutes a week. Engaging in a very healthy, nutritious, protein-heavy diet with lots of vegetables, minimizing other simple carbohydrates. Of course, of really great importance, smoking cessation, alcohol cessation, any substance use, avoiding those. Focusing on quality sleep of at least 7 to 9 hours a night, and try not to go lower than that. Sometimes that does require revamping, what we do before bed to promote sleep hygiene. Stress management, helping people be connected to a purpose in life, and then that social engagement we talked about earlier, and helping to avoid feelings of loneliness can be very helpful. And so again, lifestyle medicine, not to be a means to replace medicine, but as to be something that we do in addition to kind of help us to feel better, help our patients to feel better with doing all of these things. And then we mentioned the focus on a multidisciplinary approach in our learning outcomes, and that is really important. And at the focus of all of that, the center of everything is the patient that we provide care for. So perhaps they see an infectious disease provider, they see a separate primary care provider, or as though what has happened to many of us, the infectious disease provider ends up providing also the primary care. Perhaps they have case management, if that's an available resource to help them navigate some of those social determinants of health. They obviously would have a pharmacy of a sort to be able to get their medications from, and then addressing behavioral health and mental health support if it is needed. Then we just had these top 10 clinical pearls. I'm not going to go through all of these. We touched on every last one of these during the presentation, but I did just want to mention number 1 and number 10. So number 1, healthy aging begins with viral suppression. And that is just a really kind reminder and an appreciation to the work that we all have been doing, people that have come before us for many, many years since the beginning of HIV. We could not be where we're at today talking about aging and HIV if it wasn't for all of that work. Because again, this wouldn't be possible without medications and all of that to be able to promote viral suppression. And then healthy aging is a team sport. There's no way that any of us could do this alone. It is definitely a team sport, and I think it's just going to continue to be that way as we all learn what aging with HIV looks like in the next 10 to 15 years. Those are our references. And then now we're going to transition to our case study to kind of bring home some of the points in which we have talked about today. So this case is a gentleman in which we provide care for in our clinic. He's a 50-year-old male, Hispanic male from the Dominican Republic, who was diagnosed with HIV in 2018. At the time he was diagnosed with HIV, very shortly thereafter, he was started on a tenofovir, emtricitabine, dolutegravir-based regimen, a 3-drug regimen. And then shortly thereafter, sometime we think it was 2019, early 2020, he was switched to the 2-drug regimen, dolutegravir-lamivudine, just simply for treatment simplification. No reason other than that, but just simply that. He entered care with us in 2022 here at Midway. And just prior to joining us at Midway, he actually had been in the hospital for a myocardial infarction. He had experienced a heart attack, was admitted to the hospital, very quickly started on a high-dose statin, atorvastatin. He was managed inpatient and was following up outpatient. So he had come to us with already a history of an MI. That was before 50 years old. Hypertension, hyperlipidemia. He does have a remote history of smoking cigarettes, but he had quit over 10 years ago. He engages in insertive vaginal sex, has stable housing, has stable transportation, reports no alcohol, no drug use. And so this is a very common picture, right? The metabolic complexities, the cardiovascular complexities that go along with aging with HIV. And so these are the things that we had worked on with him over the last few years. We maintained his high intensity statin. We worked to maintain and control his blood pressure and cholesterol. We encourage and celebrate his his continued lifelong from this point forward smoking abstinence, screening for hemoglobin A1Cs, checking the weight, assessing for fatty liver disease. Through all of this, maintaining viral suppression, right? It's very interesting. Viral suppression is one little bullet on this slide. We're talking about so many other things as we're talking about healthy aging. Cancer screenings, bone density screenings, PHQ-9s, vaccinations, trying to keep up with all of these items. Well, we're doing all of that, and he did, and we were working on all of that. And he came in April 2023, and his non-fasting glucose was 118, so near normal. And then he follows up in September of 2023 for an urgent appointment. And when he called for an office appointment, he said he was experiencing excessive thirst, excessive hunger, frequent urination, and weight loss. And I believe I probably had a student at the time, and I would always wish that we did, because that way they would get to see clinically what perhaps a new diagnosis of diabetes would look like. So given those presenting symptoms, of course, we did labs. And the labs came back with a very quick call from the lab themselves with a critical lab. His glucose non-fasting was 659, and hemoglobin A1C was 13.5. So, of course, in that moment in September 2023, we asked him to go to the hospital, for which he had refused. He did not want to go to the hospital. He was afraid of what had happened the last time he was there with the MI. And so when he refused to go to the hospital, we decided to get him started on a long-acting insulin plus metformin. And the only reason why we had done that, again, was because he declined to go to the hospital. We started on Lantus 10 units, metformin 500 twice a day, sent him to the ophthalmologist for retinopathy screening, gave him really great detailed information about doing the daily foot exam. And what did we see? So we did that. In October of 2023, his finger stick glucose in the clinic was 96 on that Lantus and metformin. And then November 2023, we saw the hemoglobin A1C improve to 9.2. And then by January 2024, we were at goal with a hemoglobin A1C of 6.4. So we were really great. We were really happy to see that. And then you'll notice that navy blue box at the bottom. And again, we're building upon the fact that we even have viral suppression, which is why that part is at the bottom, serving as the base. Viral load remains suppressed on the dolutegravir 3TC regimen, and CD4, of course, was stable at 650 to 815 during this time period. So then, of course, working with people as they kind of evolve in life, he eventually comes in one day and says to us, "I'm tired of taking this daily injection with this insulin. Can you give me what I hear everybody else is getting with that weekly injection?" And we knew that he was referring to one of the GLP-1s. So we did. So since he was at goal, we were able to switch him over to semaglutide. He's actually currently maintained on the 1 milligram dose of semaglutide, knowing that it's not the max dose. But you can see his most recent hemoglobin A1C just last month was 5.9. So we've made really great progress from that time. He looks so much better now. He looks so much healthier. And again, the only reason for the switch to the GLP-1 was because he just did not want to keep injecting himself with insulin every evening. We've also kept our focus on prevention screenings. So he did not want to complete the colonoscopy. So he did complete the Cologuard, which was negative in 2025, but we're still working on the colonoscopy as the screening mechanism. He's just not ready yet. Dilated eye exam. So the most recent one was just a week or two ago. And then cardiovascular labs, his most recent LDL was about 90, and we generally keep it about 90 to 101. Ideally, with a history of an MI, we want it to be closer to 70 or below 70, but we're working on it. We haven't seen any improvement in his HDL. His HDL really just still never goes above 40. He did experience some mild hypertension in 2025, and so we had added hydrochlorothiazide to his amlodipine just to try to help maintain a little bit lower of a blood pressure for him. He did also have low vitamin D, so we did start him on weekly supplementation in 2025. But again, all building upon the fact that he has maintained complete control with the HIV with viral suppression. And now, very excitedly, his most recent hemoglobin A1C at a 5.9, which was really great. And again, now that diabetes managed with semaglutide 1 milligram a week with the metformin 500 milligrams twice a day. So this was just kind of a summary where we're at. So this gentleman was diagnosed in 2018, experienced a myocardial infarction in 2022, had a new onset of diabetes in 2023, was doing really well on insulin, a long-acting insulin and metformin, and then optimizing his regimen for him along the way, right? Whether it's treatment simplification from a 3-drug regimen to a 2-drug regimen for HIV treatment, or now even the idea of managing diabetes with a weekly injection as opposed to the daily insulin. So his preventative care is up to date. There are opportunities to improve it, as I had mentioned, because we would prefer the colonoscopy, but we were able to negotiate for a Cologuard for now for the fecal occult blood screening. And we'll take that for now until we can perhaps have him do the colonoscopy in the future. So just emphasizing a lot of what we talked about today, people aging with HIV are also going to experience comorbidities. And so what can we do to help reduce that metabolic risk? Very quickly getting that hemoglobin A1C down, working to control lipids, knowing that we still have some room to go there because again, the LDL is still just shy of 100, 90 to 100. So ideally it'd be great if it was a little bit lower than that. And so making sure that we're also working on diet, lifestyle, continuing to promote smoking cessation. Hopefully he doesn't go back to that and he can remain tobacco-free for the rest of his life. And that was all that we had. Anything else you'd like to add? Okay. And then we can take any questions.
All right. Thank you very much, Dr. Hector Bolivar and Dr. Jenn Kuretski, for what I think is a very, very comprehensive presentation and wonderful case study that you have taken us through. So I will ask our participants to go ahead and submit your questions. You can type them in or you can raise your hand and I will unmute you so you can ask your question or make your contribution. But again, thank you for taking us through a very comprehensive presentation in a very methodological way, starting us off with why aging, good definitions of aging, and then taking us through the different syndromes, looking at frailty, mental health, kidney health, metabolic syndrome, cancer, vaccination, very comprehensive in terms of how do we approach the aging population with HIV, and of course, concluding us with optimizing treatment, looking at lifestyle medicine as part of how we manage the aging population, the importance of addressing HIV and aging from a multidisciplinary team-based approach, I think is also really very important. And concluding with the study of one of your patients. So again, thank you very much. Colleagues, if you have any question, you can raise your hand. I don't see any comments. Oh, yes, there is one question in the Q&A. Do you advise, if I can go ahead and ask the question, I want to welcome Dr. Omar Swed, who is the HIV advisor for care and treatment at the Pan American Health Organization. Dr. Umar, always happy to have you. Thank you for being here. We have one question, and I'll ask Dr. Umar if you want to make any questions or any comments, you can do so. Let me ask this first question. Do you advise starting metformin in patients who are obese and pre-diabetic? Good question.
Yeah, that's a very great question. So, yeah, I can see a lot of benefit for this. And we've seen it used clinically as well. Sometimes, honestly, it's been challenging to get patients to be open to the idea, especially with HIV treatment as simple as it is now, adding on just one more pill if perhaps they have no other comorbidities yet can be a challenge. So yes, I think this is something that would be very helpful if you have buy-in from your patient to use it in that instance, especially if we know they are pre-diabetic to help prevent them from ever getting to diabetes. But I would say buy-in from the patient is the most, for me personally, that's what I have seen as the most complicated part.
I will add, not that we support it, but there is a study going on of the use of metformin to decrease the speed of aging. That study, I don't remember who's the sponsor, but there are enrolling participants if the use of metformin also is associated with some biological aspect of aging. Unfortunately, metformin has been associated with decrease in infectious diseases like COVID, for example. So I'm not sure, but just as I mentioned, that is a medication that still has a lot of uses and implications.
Yeah. Yeah.
Thank you, Shanti, for allowing me to do some comments. In first place, congratulations, Hector and Jenn, for such a wonderful presentation, very informative. I want to highlight something that resonated on me about the Jenn presentation. She said viral load is the cornerstone of the treatment for the anti-aging, the lung. And this is very important in Latin America, in particular also in the Caribbean, where more than 30% of the people appears in the first consultation, in HIV first consultation with advanced HIV disease, and also in many sites where more than 20% of patients are lost of follow-up during the first year because systems doesn't have a specific mechanism for retention. They many centers, in particular in the Caribbean, because they are afraid about stigma, confidentiality issues. There is not a standardized case management for patient that doesn't show up or do the follow-up. So this is a call for really stress the importance of maintain people undetectable. I have one question, short one, and a more general question, Chen. This patient is a very good picture of one patient that knows what he wants and really can negotiate and discuss with the provider what to do. I am happy to see that he is on dual therapy, 3TC dolutegravir, which is recommended also in the new guidance and is good for the WHO guidance. And it's good because doesn't have tenofovir, doesn't have real renal or bone problems associated, and doesn't have TAF. So help with the increased weight, etc. Does he, in any situation, ask for the long-acting injectable, for example, cabotegravir rilpivirine? He is interested on that. This is now included also in WHO guidance as a switch alternative, but unfortunately, we don't have generics yet, so it's something we need to wait until 2008, but we can start preparing for that. This is one question. The second question, the more large question. You mentioned frailty, and you mentioned three small scales that can be used for measuring. Can you elaborate a little more how those tools are and what to do when the tools show a bad result? how we
Sure.
can change that, or how can optimize the management of patient that the scale is showing bad results. Thank you, Jenn.
Yes, thank you. So for the first question, the long acting, very great question on that one. Yes, he has asked about the long acting agents. We also here at Midway offer clinical trials, and so he actually is considering enrolling in one of our clinical trials with long acting, ultra long acting cabotegravir or piperine. So possibly, so that transition may happen soon. And yes, he also came in asking for that as well. Just like you said, he's very proactive in his own care. That is definitely not every patient that comes into our clinic. Sometimes we're the one sharing new knowledge with them. This was just a unique case in which he has definitely always been in the driver's seat. And so that's an interesting perspective. To the second question on frailty, sure. Actually, let me quickly bring up, I'm going to go back to the slides just very briefly because I only chose 3 to review today. Just again, in the simplicity of going over the available tools that were out there. So the clinical frailty scale, this has a lot to do with how the patient looks sitting in front of you when you're in the exam room. It's basically, I think it's like you grade it 1 to 7 or 1 to 9. It has pictures that are associated with it. It has a lot to do with their cognition, their ability to get up out of the chair, how you see them able to move. Do they report fatigue? And then depending upon, 1 to 9, if it is a more like a higher rated quote frailty score, recommending support services for whatever it may be. So if you notice that they're having difficulty getting up out of the chair, perhaps recommending physical therapy, or if it's that they're very thin and you can see a lot of muscle mass, are we recommending protein consumption for that? Things like that. That's how you would recommend, or that's how you would navigate what the results were on your frailty assessment. The second two, the frail scale and the timed up and go, those are actually tools where you would ask the patient questions. So for the frail scale, a lot of times it has a Likert scale where you're asked the patient, how often do you feel like you are connected to others and, experience, a purpose in life? All the time, some of the time, neutral, none of the time, some of the time, whatever it may be. And then you add up the score, and depending upon what each one of those responses are, will depend upon how you develop that intervention. Acknowledging, though, that not, a lot of us don't have necessarily access to all the resources needed to be able to navigate that. And so acknowledging that is also a limitation with some frailty assessments, is it's challenging to actually be able to implement an intervention. And then timed up and go, this has a lot to do with gait speed, hand grip, so on and so forth. So those are just some of the simple ones. You'll see there's other much more complex, longer tools that are out there, and they basically combine all of that into one. And some, if I'm not mistaken, also include family members' interpretation too. As we know, sometimes people are aging and we get more information from the people that come with them to their appointments, sometimes than the people that are sitting right in front of us.
Yeah, thank you. No, it's very impressive. Thank you very much.
Yeah. Thank you, Dr. Mar, for the question. Thank you, Dr. Bolivar and Dr. Kuretski. We have a few more questions, but I also see in the audience we have persons who are from large treatment sites. And so I want to pose the same question that Dr. Omar posed to Dr. Kuretski. You have one participant indicated that there are a lot of aging patients in their clinic. And so how are you measuring frailty and how are you managing frailty? And Dr. Kuretski spoke on some of their own experiences. So anyone who would like to touch on that, please raise your hand and I will open a microphone for you to speak. We do have a few questions in the meanwhile. I have a question here that's asking, now that we are reaching an undetectable viral load in our patients, so we're achieving this for the majority of our patients, how should national monitoring and evaluation frameworks redefine success to track health span and quality of life rather than just survival? Anyone?
So I think that developing a way to really evaluate quality of life would be something that would be like perhaps the fourth or fifth 95%. I do think we have to pick it up after reaching viral suppression. In clinical trials across the world, we do have a big emphasis on patient-reported outcomes, and I think this starts to point in that direction of we're building upon viral suppression. And so whether we're using, quality of life assessments or HIV symptom assessments, or simply maybe mental health assessments like PHQ-9s, I think that would be a really helpful next step. And then I wouldn't be surprised if in the next 10 to 15 years, we start to see some evaluation of frailty as a standard, right? Because frailty doesn't necessarily have to happen. We can do things to try to intervene to minimize frailty. So I wouldn't be surprised if that care continuum extends to include something related to frailty.
Thank you, Dr. Kuretski. I know some of the more developed countries are looking at happiness index. So I think it'd be good for us to get there as well. There are two other questions in the Q&A, and I will merge them. They're very similar questions. So can you speak a little bit more about the management of chronic inflammation in some aging patients? And what are your thoughts on screening for inflammatory markers as risk factors for insulin resistance and cancer?
Let me start with the second question. Inflammatory markers, that's a whole chapter in clinical care and in research. Unfortunately, there are probably 300 inflammatory markers, and doing that commercially for every patient will be impossible. Still, there is no one single best inflammatory marker to assess for cardiovascular risk, for example, or other conditions. We can use C-reactive protein, we can use interleukins, we can use cytokines, but those are not, in the majority of the times, many of the inflammatory markers are not commercially available, and it's impossible to do it with patients unless we're doing research and we participate in clinical trials or cooperate with the basic scientists. Insulin resistant is probably more affordable in terms of or how to address for doing, for example, hemoglobin A1C regularly and not waiting until we have an elevated glucose level. And we can go even more than that, is doing genomic studies, because at the genomic level there are markers to predispose us to some diseases like diabetes, for example. That is definitely an association between some genomes and some mutations or some particular type of genes associated with more or less chances to develop a particular disease. There are countries like the United Kingdom or Iceland where they have extensive genomic population studies, and they are identifying risk factors for the most common diseases in those countries. Like in Iceland, for example, rheumatoid arthritis and osteoarthritis, that is very common in that population, also fatty liver. So if we eventually in the future we will be able to do pharmacogenomics and genomic studies, it will be even better than doing inflammatory markers, because we may have some idea what of our patients may have more predisposition to one disease or another, and probably intervene earlier and not waiting until a patient is newly diagnosed with one or another condition. Regarding the first question, that I forgot what was the first question. Oh, how to modify inflammation in aging. Unfortunately, other than lifestyle modification and trying to minimize the amount of medications, are using less to obtain more, like dual therapies instead of using tenofovir, for example, that Dr. Sudet mentioned. So those tiny interventions may have huge repercussions. Unfortunately, there is no a magic pill there to reduce inflammation, no even metformin or any other medication. There is a lot of hopes that these GLP-1 receptor medication definitely not only are decreasing weight, but are probably reducing the cardiovascular risk. Also has been used in, and now there are studies here by the NIH in mental health, because apparently has a big impact on substance abuse. We have patients that are referring That's once they start using this medication, they have less use of alcohol. They don't have craving for alcohol, and that's a big thing. Probably in that line, we will intervene better once we have more information.
Thank you, Dr. Bolivar. I know Dr. Emmanuel Cummins, who posed the question on the inflammatory markers, is a professor at the University of Guyana and has been studying this widely. Dr. Cummins, if you want to have a follow-up question or comment, you can raise your hand and I'll open the microphone for you to speak. But colleagues, there is the second follow-up poll that's on your screen. I encourage you to respond to the poll, and if there are any other questions, please type them in the question and answer panel on your screen, and we'll take them. I can give 2 more minutes for the poll and for any additional questions. Anything else from you, Dr. Swade?
No, Shanti.
No?
problem.
All right,
Thank you very much.
All right, so colleagues, please go ahead, respond to the poll for us, and let me just wrap up. We're at time actually, which is really good. So on behalf of the Pan American Health Organization and our participants today, thank you, Dr. Bolivar, and thank you, Dr. Kuretski, and thanks to Midway Care for always being responsive and available to support us in education and capacity building in the Caribbean. So colleagues, you can use your reaction and let's give them a big round of applause. Thank you very much for presenting to both of you. Thank you, colleagues, for you being here with us, for your engagement and your questions and your contributions. As I said at the beginning, you will receive the PowerPoint slide set in the upcoming days, but you will also receive a post-event survey. And so I kindly ask that you provide us with your feedback. It's not a knowledge survey, it's an experiential survey. Tell us what you liked about the webinar, what you valued most, etc. What's upcoming for us on July 14, Dr. Nicholas Elliott from Guyana Ministry of Health will share Guyana's experience in monitoring and evaluation of their EMTCT Plus initiative. And on August 4th, infectious disease specialist Dr. Lauren Dowdy will present to us on central nervous system infections in people with advanced HIV disease. So we have 2 interesting sessions to look forward to. And again, I encourage you to please continue responding to the poll. I will go ahead and close and say again, thanks to Dr. Bolivar and Dr. Kuretski. Thanks, everyone. Do stay well and see you at our upcoming sessions. Thank you very much, everybody. Colleague, do have a good day.